The subcommittee will be called to order. We're minus a gavel today, but I don't think we really need it. Let me announce that the hearing this morning is on the Ryan White Care Act amendments of 2009, actually a discussion draft, so we don't have a bill number. And I'll recognize myself initially for an opening statement. This discussion draft has been circulated by Chairman Waxman and myself and is based in large part on the community consensus document that was put together by a large number of AIDS groups from all across the country. Though we will be using this discussion draft as a basis for our hearing today, it's very much a draft, and I'm interested in having conversations with the minority as well as with the Senate in an effort to come up with a strong piece of legislation that can be passed by both chambers and be signed into law by the President. The Ryan White Care Act, as many of you know, was named after a young boy who contracted the AIDS virus from a blood transfusion and sadly lost his life to this horrible disease. Since his death in 1990, we as a nation have made great strides in preventing and treating HIV/AIDS in large part due to the Ryan White program. Once a guaranteed death sentence, an HIV or AIDS diagnosis today means a complicated and expensive mix of drugs and therapies that can allow individuals to live longer and more prolific lives, and for many, new knowledge of the disease has allowed for better and more targeted prevention programs that have slowed the spread of HIV/AIDS. In spite of these advancements, however, there are nearly 40,000 new HIV/AIDS infections reported each year, and according to the CDC, approximately 1.1 million Americans are currently living with the disease. Since the beginning of this epidemic, an estimated 580,000 Americans with AIDS have died. So I think it's more crucial than ever, given the high number of Americans suffering from the disease, that we have the Ryan White program. Accounting for roughly 10%, or I should say 19% of all federal funds that are used on HIV/AIDS care, the program provides treatment and support services to individuals and families living with the AIDS virus and serves over 500,000 low-income Americans. The program is without a doubt extremely vital in our battle against this epidemic. In 2006, Congress reauthorized the Ryan White program and included a sunset provision that will eliminate the program entirely on October 1st of this year. And I think I'm pretty certain in saying that everyone in this room today does not want that to happen. And that's why Chairman Waxman and I have released the draft legislation we're examining today. The discussion draft before us is based on the community consensus document and would make a few minor improvements to the Ryan White program. It eliminates the sunset provision so that we'll never face a last-minute scramble to sustain vital services to our communities. In addition, it would extend the current program for 3 years and provide more flexibility for the appropriators to adequately fund the Ryan White program to best serve the evolving needs of patients, families, and communities. The discussion draft extends the exemption period for states that are still reporting their HIV cases under a code-based system. It will allow those states to get their names-based systems fully up and running and to ensure that their data is accurate and useful. In that same vein, it would also ensure that no transitional grant area, or TGA, would lose their status for the duration of this extension. It would continue the hold harmless provisions that were established during the 2006 reauthorization, which protects grantees from large decreases in funding so that we don't disrupt the provision of care to patients. We've also included a few more technical tweaks to the current Ryan White program, all of which guarantee that patients continue to be able to access these life-saving and life-sustaining treatments and services. As I mentioned before, the Ryan White Care Act is scheduled to sunset on September 30th, so we must act now to ensure that the patients continue receiving the excellent care that this program provides. And I sincerely hope that we'll be able to work in a productive, bipartisan, bicameral fashion to create a bill that will benefit over 1 million citizens fighting this disease in the United States. And I want to thank the AIDS community for their hard work in coming together on the consensus document. We greatly appreciate the work you've done. And I'll now recognize, well, Mr. Deal isn't here, so I have my colleague from Kentucky acting as the ranking member today. Mr. Wakefield is recognized.
Chairman Plone, thank you very much for holding this hearing on the discussion draft to reauthorize the Ryan White legislation. All of us are very supportive of the Ryan White program, and back in 2006 we were happy to work in a bipartisan manner to reauthorize that program for 3 years. We do take you at your word today to work with us in a bipartisan way as we move forward to reauthorize this draft. And I might say that while we love this program and we recognize the benefits of this program, I have two particular areas of concern. Number one, in the discussion draft, we authorize such sums as necessary for 2010-2012. When you consider the financial condition of our country right now, our constituents and practically every economist from every spectrum are very much concerned about the size of our debt. So number one, we spent about $2.2 billion on this program last year. And another reason that I really have concern about the open-endedness of this is that we have a tendency, not necessarily this committee, but I think all committees have a tendency of relinquishing more and more authority to appropriators. That's precisely what this legislation does, such sums as necessary. So I think we would be better off putting in a number that we authorize for the two reasons that I have mentioned. I would also say that another area that I'm concerned about is the grandfathering of these transitional grant areas. There are requirements that must be met for the transitional grant areas to receive money. And under this discussion draft, if you had an area that was receiving grant money for the last 3 years, then they would automatically be grandfathered for another 3 years. And it certainly is possible that the need may be greater in some other area. So those are two areas that I particularly am concerned about. But once again, we're delighted that you're holding this important meeting on the discussion draft, and we hope that we can work with you and reach a consensus on this legislation and get it reported out of committee. Thank you very much.
Thank you. Recognize the chairman of our full committee, Mr. Waxman.
Thank you very much, Mr. Chairman. Since its inception in 1990, the Ryan White program has played a critical role in addressing this country's AIDS/HIV epidemic. Today, some 500,000 Americans rely on the program for basic care, treatment, and support services. It's hard to imagine how patients, their families, and our states would be able to deal with the epidemic without this program in place, which is why it is so important that we act as quickly as possible to reauthorize the program. With today's hearing, we begin that process, which I hope will culminate in a piece of legislation that members from both sides of the aisle can strongly support. I believe that the discussion draft we are reviewing today makes for an excellent start towards that end. It contains no major changes to the program. Indeed, most of its sections either extend existing policies or clarify parts of current law that have caused confusion. Others make changes to mitigate destabilizing funding decreases that have resulted from the application of the 2006 reauthorization. We'll hear more about these specific provisions from our witnesses today. I think an overarching theme that will emerge is that with some relatively plain fine-tuning, the Ryan White program can continue to do its good work, providing services to those most in need for another 3 years. This is especially important because of the program's looming sunset deadline of September 30th. A quick reauthorization will give grantees the stability they need to plan, retain staff, and maintain life-saving services for their clients. The painful budget cuts that we're seeing in so many of our states make it all the more important to provide that stability. That said, I want to underscore the word draft that is in the title of the document that's the subject of today's hearing. This draft was informed by technical assistance from the administration, as well as a community consensus paper that has been endorsed by nearly 300 organizations in 47 states. But this is just the starting point. We've already begun talking through various issues raised in the draft in a bipartisan fashion. Soon we'll begin negotiations with our colleagues in the Senate with the commitment to doing our best to reach an agreement before the end of this month. That will take much hard work, but I believe we can get there. We simply have to. The people who depend on the Ryan White program for the services they need can't wait. I look forward to working with all our colleagues on this committee in ensuring that we reach this goal and that an even stronger Ryan White program will be in our communities for another 3 years. Thank you, Mr. Chairman.
Thank you, Chairman Waxman. Next, the gentleman from Pennsylvania, Mr. Pitts. Waves. Gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. You know, with all the focus on health care reform in Congress right now, the Ryan White Care Act probably isn't foremost on the minds of Americans. In fact, probably many of our colleagues aren't even aware of what the Care Act is and what it does. You know, in an ideal world, we wouldn't have the Care Act because we would have already found a cure and we would already have a reliable vaccine for this disease and prevent it before it occurs. And that still needs to be our foremost thought and our ultimate goal. I understand how dangerous HIV/AIDS is and how important it is to have adequate resources to prevent infection and to manage the disease. Over 1 million Americans are infected, and nearly a quarter of those individuals are unaware that they carry the infection and are thus at risk for continuing the spread. My home state of Texas is consistently in the top 5 with respect to the number of HIV and AIDS infections. I represent a district in North Texas that has been experiencing a rise in new cases. The face of AIDS has changed, and we have a responsibility to ensure that the CARE Act is meeting the needs of those AIDS patients today. In the state of Texas, almost half of all HIV and AIDS infections are occurring in the African American population. The average HIV rate per 100,000 population for Tarrant County, one of my counties, is 3 times greater in the African American community than in other communities. In fact, HIV infections are increasing throughout the South. We saw a spike of AIDS cases in the mid-1990s and a decline in the late 1990s, and now the rates have begun to increase again and to climb ever upwards. In fact, Mr. Chairman, if we look at the way the Ryan White Care Act is structured, it's also important for me to ensure that my constituents in both rural and urban areas be equally served by this act. The committee has made some important changes in the legislation passed in a bipartisan manner out of this committee in 2006. Unfortunately, some of those changes never made it into law, and I hope we simply don't kick the can down the road and we invest the time necessary to really create the Ryan White Care Act for the 21st century. I am saddened that it appears we're preparing to just push through a bill. We've proven just a few short years ago that this is an issue that Republicans and Democrats can agree on and can come together on. Congress has the opportunity to provide a better health care delivery system, moving from a palliative care model to a blended chronic care model that recognizes HIV as an increasingly manageable disease. And again, let me stress, we need sufficient funding for vaccine research. We need sufficient funding about actually finding a cure. No one should be come out on the short end of the stick because of where they live, because Congress simply decided to rush something through. If we really care about this population, we will focus on patients, and make sure that we take the time to work across the aisle to produce such a bill. Thank you, Mr. Chairman. I'll yield back the balance of my time.
Thank you. Chairman Dingell.
Good morning, Mr. Chairman, and thank you for holding this important hearing. I also want to thank today's witnesses for joining us. I wish to applaud the National Alliance of State and Territorial AIDS Directors, the AIDS Action, and other members of the Ryan White Working Group. Your year-long cooperation and collaboration and consensus of priorities from the HIV/AIDS communities will make our work easier. Today is an important hearing for many reasons. The first is the importance of the subject matter. The second is the fact that the Ryan White program will expire on September 30 of this year. That means we have a deadline against which we must work. We cannot let this program expire. Since 1990, the Ryan White program has been one of the most important pieces of our domestic response to the HIV/AIDS epidemic. It funds health care and support services for persons living with AIDS and HIV. The dollars spent here help over 500,000 people every year. As a payer of last resort, the Ryan White program is a critical piece of our social safety net, protecting some of our most vulnerable citizens, including more than 13,000 people living with HIV/AIDS in my home state of Michigan alone. I would also note that this is a program which is a very important defense to our society against the transmission and the expansion of the AIDS virus further into our society. According to the Kaiser Family Foundation, most of the patients who receive services from the Ryan White funds are low income. About 72% have incomes at or below the poverty level. 33% are without insurance. 56% are underinsured. I'm working hard to make sure we pass this important health care reform this year so that no American goes without insurance. However, even after all the proposed insurance market reforms go into effect, we will need extra funding for wraparound services that meet the specific needs of HIV/AIDS patients. The Ryan White program also helps to keep the doors of community health clinics open to people with HIV/AIDS that have no place else to turn. During our health care reform discussions, we have talked at length about the value of medical home model that provides continuous, coordinated, and comprehensive care to individuals. Many of these HIV/AIDS clinics have been operating as medical homes before we even had the terminology and have been doing so with Ryan White funds. Finally, this program is vital to our states and metropolitan areas. Without federal funding for the Ryan White programs, states and localities will be left on the hook for a substantial portion of HIV/AIDS care, and the society will be greatly increased in the risk that it faces from HIV/AIDS. We cannot pass the burden on to the cities and the states and the communities, especially in the midst of calamitous budget shortfalls that they all confront. I urge my colleagues in this room to work collaboratively and, unfortunately, with great swiftness to ensure that we meet the September 30 deadline and to minimize the disruption of funding and services for people living with HIV/AIDS. This program is too important to disappear, and the dangers of letting that happen are far too great. I thank you, Mr. Chairman. I yield back the balance of my time.
Thank you, Chairman Dingell. Next is the gentleman from Georgia, Mr. Gingrey. Waves. And then a gentleman from Illinois, Mr. Shimkus.
Thank you, Mr. Chairman. I'd like to say to my colleagues, welcome back from our break. It's good to be here, and I look forward to a productive fall. This is a good start. Ryan White is supported, as was stated by many, by a bipartisan group of members. I'm not falling in the category that we have to move quickly or rapidly. I think we're learning that that's not always the best way to deal with public policy. We could do a simple reauthorization with no changes. Unfortunately, we're falling down also the same trap as addressing draft bills, and I hope that if and when after this hearing we heard changes and corrections and a bill finally gets submitted, that we would have a legislative hearing on the bill. It has been the history of this committee to do that. It hasn't been the current history of this committee to do that. So we're kind of back where we started from before the break, having hearings on draft legislation instead of real legislation, and I hope we change course with that. And I am happy to be back and happy to see all my colleagues, and I yield back my time.
Thank the gentleman. A gentleman from New York, Mr. Engel.
Well, thank you, Mr. Chairman, for holding this important hearing on the Ryan White Care Act reauthorization. The Ryan White Care Act holds a very special significance to my state, New York. We are unfortunately home to 16% of the nation's AIDS population. And so New York remains the epicenter of the HIV/AIDS crisis. New York has nearly 120,000 residents living with HIV/AIDS, and our state and cities have been proud to partner with the federal government in providing care for many of these individuals. New York State receives more than $300 million in Ryan White funds under all parts of this act to provide a range of health care and support services. Through Ryan White programs, 22,000 uninsured New Yorkers receive medications and ambulatory care services, and thousands more receive other essential services such as mental health, case management, nutrition, and treatment adherence support services. These individuals must be guaranteed uninterrupted access to these vital services. It's critical that Congress act swiftly on the reauthorization of the Ryan White Reauthorization Act, which nationwide provides life-saving medications, health care, and support services to over 500,000 people. As you know, unlike most reauthorizations, Congress inserted a sunset provision into the Act in 2006, requiring congressional action by September 30th of this year, 2009. Without action, this important program will be terminated and care will be jeopardized. While 3 years ago this reauthorization was the subject of much disagreement and dissent, and I remember because I was in the middle of it, we are in a different place today. Fortunately, members on both sides of the aisle and more than 250 organizations in the U.S. have worked hard over the past year to develop legislative principles where there is much agreement. The committee draft proposal is for a 3-year reauthorization of the Ryan White HIV/AIDS Treatment Modernization Act. While some might ask why are we again working to re-implement a relatively short reauthorization, there's good reason. The 2006 reauthorization took effect in 2007 and included several significant changes that have not yet been fully implemented or assessed. In addition, greater policy discussions likely to impact the program, such as the development of a national AIDS strategy and broader health care reform, are underway. Indeed, the health reform legislation that we're continuing to develop, once fully implemented, will have a profound effect on our ability to provide access to health care and prevention services to individuals with HIV/AIDS nationwide. As currently drafted, we will reform the private insurance market and end the practice of excluding beneficiaries for pre-existing conditions. We will reform Medicaid by allowing early treatment for individuals with HIV before they are disabled by AIDS in the first 3 years of enactment, and will in fact expand Medicaid eligibility to cover low-income childless adults. I'm proud of the work that I've done with you, Mr. Chairman, and others to ensure that. Long-term, we'll create exchanges for the purpose of insurance with subsidies for low-income individuals. And finally, we will close the Medicare Part D donut hole over time. While these are significant changes in our health care delivery system, we will still need the Ryan White program, which remains the payer of last resort to address unmet needs and services, particularly over the next 3 years. In conclusion, Mr. Chairman, I want to commend you. I want to commend you for the draft bill, which addresses many of the points raised in the community consensus document, as well as the specific concerns of my home state. While there are some issues related to rebates and grant funding that I will continue to work with the chairman on prior things to mark up, I support the draft bill and look forward to the discussion today. And again, Mr. Chairman, I want to emphasize our thanks to you because you have been such an important and integral player in this and have been so supportive that we really need to publicly thank all the work you've done. I yield back.
Thank you. The gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman. I appreciate the hearing that we're having today and want to welcome our witnesses. In 2006, my colleagues and I passed what I think was a thoughtful bipartisan reauthorization of the Ryan White CARE Act. The reauthorization has proven very successful in the Tennessee HIV/AIDS community and has assisted more than 7,800 low-income Tennesseans with medical services, medications, dental service, drug abuse, mental health, and related health care needs. The Ryan White program provides an important safety net in assisting the underinsured in keeping health insurance and provides care to the uninsured. The program reinforces the fact that keeping people on private insurance provides great benefit to the individual and to the community. We have seen success with this program. As we move forward with the Ryan White reauthorization, it is imperative that this committee work in a bipartisan manner to best serve the recipients of this program and to meet their needs. Congress needs to be good stewards of federal funds. Our constituents, if we have learned anything in August, what we have learned from our constituents is that they see it as an imperative, and so should we, that we be good stewards of the federal funds and that we place appropriate funding and spending limits in place and not open-end those authorizations. Access to care is one of the biggest concerns among my constituents. There are real problems in health care, but what we know is replacing private care with a government bureaucrat won't increase access, and it will not fix our health care system. In Tennessee, via the TennCare program, we have learned that lesson the hard way. My constituents also want us to spend less money to fix the problems that exist in health care, and my colleagues on this side of the aisle have joined me in offering plans for doing that. My constituents are telling us repeatedly that they do not want another $800 billion in higher taxes for a government-run plan that is not going to make health care better or cheaper or more available. They realize that there are issues that need to be addressed, just as they realize there are programs that have worked in a bipartisan manner. And as we look at the Ryan White Care Act, which has worked, when appropriately addressed, my hope is that we're going to begin to start forward on a new path and that we will approach these issues working together in this committee. I thank the chairman. I yield back.
Thank you. Gentlewoman from California, Ms. Harmon.
Thank you, Mr. Chairman. I choose to be an optimist, and I think the fact that this committee is basically together on the importance of the Ryan White Act may be a good omen for the health care fights in the next few weeks. It is crucial that we stay together on this cause and that we consider carefully the discussion draft, which will be part of a hearing today. We are having a hearing in this committee, and resolve quickly what changes we want to make to that draft and enact it, hopefully on a reported on, hopefully on a bipartisan basis. When we talk about HIV and AIDS, it is easy to forget the very human face of the disease. It has had a profound impact on the lives of many of my constituents and friends, and I'm sure everyone on this committee can tell stories like this. But one of them was particularly well known. Elizabeth Glazer touched my life deeply. She contracted AIDS in a blood transfusion, which she got giving birth in 1981, and unknowingly transmitted the virus to that child and to her subsequent child. When she became deathly ill with the disease, she dedicated her life to raising awareness of pediatric AIDS, and a foundation bearing her name raises millions of dollars to help others. So it's with Elizabeth in mind that I urge prompt action on the discussion draft. This program provides critical medical care and support services to people with HIV/AIDS across the country, and it is especially important to metropolitan areas like Los Angeles County, which has the second highest number of HIV/AIDS patients in the country. Ryan White spends about $35 million a year to help provide 25,000 Angelenos with care. The program is truly a safety net. It is a payer of last resort, so it only picks up the costs after other sources of funding are exhausted. It helps the neediest patients, as has been pointed out. A third of them have no insurance, and more than half are underinsured. In the current economic climate, this care is absolutely a matter of life and death. Faced with a budget shortfall, California was forced to cut some of its funding for HIV/AIDS, and moreover, rising unemployment and the growing ranks of the uninsured means more and more people are turning to this program for help. I'll skip the examples. We all know what they are. For all the good it does, Ryan White comes at a relatively low cost. It represents less than 10% of federal HIV/AIDS spending. I strongly urge that we pull together on a bipartisan basis and do the right thing, and that is to enact the discussion draft, I think, close to its present form. But if small changes are needed to be made, let's make them on a bipartisan basis and get on with it. I yield back my time.
Thank you. Gentlewoman from Florida, Ms. Castor.
Chairman Pallone, thank you very much for convening this timely hearing to address the discussion draft and that will reauthorize the Ryan White initiative. I look forward to the expert testimony today. We must act expeditiously because we are facing sunset, and so many of our neighbors living with HIV and AIDS are depending on us. In my home state of Florida, the Ryan White initiative has prolonged the lives of many men and women affected by this devastating disease. In 2004, Ryan White assisted well over 100,000 patients and nearly 13,000 family members of people living with HIV and AIDS. And those numbers, unfortunately, continue to rise. The stories of the impact that the Ryan White Initiative has had on my neighbors exemplify the strength of human nature to persevere and to meet adversity head on. And I'd like to share with you two short stories from back home in Florida, stories that display the life-changing impact that Ryan White has had on many lives. Christopher from Florida says, I was diagnosed with HIV back in the summer of 2000, and I was fresh out of college with no health insurance. It was only through government-assisted programs that were funded largely by the Ryan White Initiative that I was able to have checkups and blood work done. I was a patient at Pinellas Care Clinic in St. Petersburg, Florida. I have since begun working and have had insurance for 4 years, but could not have gotten through those 5 years without the assistance of the Ryan White Initiative. Mary from Florida relayed to me, I have lived with HIV/AIDS since 1990. When I became ill in December 2008, I had to leave my part-time job. With co-payments on medications and medical visits, I was at the point of choosing to eat or stop taking medical services. After contacting a Ryan White case management agency, I was helped out with financial assistance. I can honestly say if Ryan White had not been in place, I believe I would be dead. There are many like myself here in the United States who need just a little help to continue to be productive members of society. Mr. Chairman, the Ryan White Initiative is the only true lifeline for many people living with HIV/AIDS, many of whom are oftentimes barred from private health insurance. So I strongly urge the committee to move quickly to update and reauthorize Ryan White before the September 30th sunset date. I yield back my time.
Thank you. Gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman, for holding a hearing today on the discussion draft of the reauthorization of the Ryan White Care Act. Since its establishment in 1990, the Ryan White Care Act has delivered much-needed funding to states and urban areas with large numbers of individuals living with AIDS, the A.H.I.V.S virus. More than half of the Americans living with AIDS live in 5 states, New York, California, Florida, New Jersey, and my home state of Texas. Unfortunately, in my state of Texas, the number of individuals living with HIV and AIDS increased in the last 10 years. With 2 eligible metropolitan areas and 3 transitional grant areas in our state, Texas relies on Ryan White dollars to provide quality, life-prolonging care to Texans living with HIV and AIDS. In fact, Ryan White funding helps to provide critical care and support service more than 18,000 in 2006. My hometown of Houston is currently the 8th largest EMA in the nation, with approximately 10,000 individuals living with AIDS, according to the CDC statistics. In the community of Harris County, our hospital district utilizes more than $26 million each year to coordinate essential health care and support service. There's 21,000 individuals in our community living with HIV and AIDS. The importance of the program cannot be underestimated. Without CARE Act funds, many Americans living with HIV and AIDS would have no other source for treatment. The last time we were authorized CARE Act in 2006, we had quite a battle, and I'm pleased Nearly 300 HIV/AIDS groups came together across the U.S. to give this committee unified recommendations on the provisions to be included in the reauthorization of this bill. Many of their recommendations have been addressed in this draft. Our office has been in contact with several of our local HIV/AIDS organizations to ensure Texas will continue to be able to access the critical care services provided by the CARE Act in this draft, and we look forward to carefully at several provisions in the draft. Texas was held harmless in FY09. Its base funding was held at 95% of the 06 levels, even though the award would have declined more if based solely on case counts. Section 5 of the discussion draft allows a hold harmless funding to continue and eliminates the need for repeated legislative action by including this funding in the baseline appropriations request. We heard from groups in Texas about the need to include a fix for ADAPT rebates and unobligated funds. Section 6 and 7 of the discussion draft take steps to ensure that states will give some flexibility with regard to unobligated funds from this program. Unobligated funds must be returned unless a waiver is granted, but the ability to have some flexibility in the section is important. Thus far, this committee has been working on a bipartisan basis on the discussion draft, and I hope we will continue to work together and quickly move the Ryan Act reauthorization out of our committee. And as we know, the current legislation expires September 30th, so we have a very limited amount of time to ensure funding continues to this program. And I yield back my time.
Thank you. Our Vice Chair, gentlewoman from California, Ms. Capps.
Thank you, Mr. Chairman. I'm very pleased that the subcommittee is meeting on this important subject. I thank the panelists in advance for being here today and for the testimony you'll be giving. The reauthorization of the Ryan White CARE Act is a critical issue for this committee, for the HIV/AIDS community, and indeed for our entire country. I look forward to a productive discussion today about how we can focus on the ways we can strengthen the CARE Act so that it continues to meet the health needs of persons living with HIV disease and their families, especially as they are living longer, which is a good thing. This issue is especially important to my home state of California, as my colleagues who are from the same state are here as well, which has the second largest disease burden in the United States and a significant number of new cases each year, particularly amongst the Latino population. As you know, California is experiencing a severe budget crisis. State AIDS funding has been drastically reduced. My constituents and all those affected across the state need this assistance from Ryan White all more than ever. Too often their livelihood and that of their families depends on this care. I want to associate myself with the remarks of my colleague from Texas, Dr. Burgess. As one who also represents portions of a rural area, 3 mid-sized counties on the central coast of California, I'm concerned that funds are disproportionately assigned to more urban areas. I represent the main source of HIV services between Los Angeles and San Francisco, and I want to ensure that Central Coast providers have what they need to provide resources. September 30th will be here before we know it. We must act now to reauthorize this legislation. I'm interested to hear from our panelists today about how we can work together. And we can work together in a bipartisan way, I believe, on this committee to ensure that the thousands of members of our HIV community in California and across the country continue to receive health care and support services. Thank you for your testimony, and I look forward to hearing it. I yield back.
Thank you. Gentlewoman from California, Ms. Eshoo.
Thank you, Mr. Chairman, for holding this hearing today and for your leadership on this issue, which is such an important one to people across the country in every single community that have been diagnosed with HIV/AIDS, and what the Ryan White CARE Act represents to them. It's a very, very important effort that has worked, that has received bipartisan support in the Congress. It's provided billions of dollars, and most importantly, it has helped to not only improve lives, save lives, but extend the lives of our fellow citizens. So I'm pleased that this reauthorization is a priority for the committee, obviously as it is for me. When we reauthorized the Act 3 years ago, I thought that the legislation failed to uphold the tradition of the original legislation because it created a system of what I termed winners and losers in the allocation of federal resources. At that time, I offered an amendment in committee with several of my colleagues from the California, New York, and New Jersey delegations to increase the overall authorizations in the bill and to extend the hold harmless provisions of the bill by 2 years to ensure that the historic epicenters of the disease do not experience precipitous declines in funding levels from year to year. Unfortunately, our amendment was defeated by a single vote, by just a single vote. Now, this sounds like the old formula fights, which bring out, I guess maybe in some ways, the worst in Congress, but they are fought really hard. But there's a human face to this. And so if the funding is not at the appropriate levels and distributed appropriately, there are human beings that fall through the net, and they're hanging on as it is. If not for the stopgap funding during the past 2 appropriation cycles and the FY10 bill, my district, and very importantly the state of California, the largest in the nation, would have lost millions of critical dollars to help those living with AIDS and HIV and who were the most in need. So I look forward to reauthorizing this bill at appropriate funding levels, including a hold harmless provision, so that states will not experience destabilizing shifts in funding from year to year. People can't live that way, and so the funding should not be set up that way. My thanks to the witnesses that are here today for your incredible work that I think our entire country is grateful to you for. And thank you again, Mr. Chairman, for bringing this up. And I look forward to a really solid, fair, well-funded bill so that all of the promise that Ryan White CARE Act holds will really reach all the people that it was originally intended to. Thank you.
Thank you. Gentleman from Maryland, Mr. Sarbanes.
Thank you very much, Mr. Chairman. It's a privilege to be able to consider this bill today, and thank you for bringing the draft to us. This is an absolutely critical reauthorization that we are considering. You know, nothing says more about who we are as a nation than the way we step forward and respond to the needs of those who are living with HIV and AIDS. So this Ryan White CARE Act and the reauthorization of it is critical to who we are as a nation. It bears repeating. I think Congressman Green mentioned this, but there's nearly 300 organizations across the country who've worked together to form a consensus about what the recommendations should be and what should be included in this reauthorization. And I want to salute every single one of those organizations for their work. That's an incredible level of advocacy and collaboration. It's why we're able to move this kind of legislation forward, and it represents the best in terms of partnership between advocacy groups and people who are on the ground dealing with issues out there, and those of us in Congress who are trying to respond. We're on a tight timeline, of course, that's been alluded to. My hope is that we can work in a bipartisan fashion to get this legislation done so that we don't hit this hard sunset that we're concerned about. I think that can happen, and obviously starting right today as we begin our September business, starting with this issue puts us on the road to getting that done by the end of September. I do want to mention that Maryland has been hard hit by HIV and AIDS, Baltimore in particular, which is part of my district. And there are some tremendous organizations throughout the state and in the city of Baltimore who've been working for many, many years to address these concerns. There's a group here today, LifeLink, and actually I'd like you to raise your hands just so people can see how many of you are out there. That's the kind of advocacy that has brought forward this kind of legislation. And I want to salute everybody who made the trip over to be at this hearing. I look forward to the testimony of the witnesses. I look forward to moving this bill in a timely way. And I yield back my time. Thank you.
Thank you. Gentlewoman from Ohio, Ms. Sutton.
Thank you, Chairman Pallone, for holding this important hearing on the reauthorization of the Ryan White Care Act. Since it was passed in 1990, the Ryan White Care Act has provided critically needed help to states and communities to provide treatment and services for individuals stricken with HIV and AIDS. And this legislation, as we've heard, provides federal funds to cities and states to ensure that necessary medical HIV and AIDS treatment can be given to all individuals, regardless of their race, age, or social standing. And we should be clear, Mr. Chairman, that AIDS is still epidemic in this country. According to the district's HIV/AIDS administration, in Washington, D.C., a reported 3% of district residents right outside of these committee doors are living with HIV and AIDS. And as a matter of perspective, in this one city alone, that rate is higher than in West Africa. But we have a chance this month to offer continued protection to one of our nation's most vulnerable populations, those living with HIV and AIDS. And those who are stricken with HIV and AIDS often live in urban areas and have trouble accessing the healthcare system. In 2008, Ohio ranked the 14th highest among the 50 states in cumulative reported AIDS cases. One of the most hard-hit areas of the state is Cuyahoga County, part of which I represent. And last year, there was a decrease in the number of new AIDS cases in the county, and that's good news, but we cannot become complacent. And unfortunately, in 2008, the county saw a slight increase in new HIV cases, and the disease continues to take a disproportionate toll on minority populations. While African Americans make up 29.3% of the Cuyahoga County population, they make up 56% of reported persons living with HIV and AIDS in the county. And the Minority AIDS Initiative was created in 1998 by Congress and the administration to address this very problem. The Minority AIDS Initiative has been a positive program, and I look forward to hearing the results of the GAO report on this subject. We must continue to give our states and communities the funding they need to help those who have the disease. We must also increase education and outreach to prevent the spread of HIV and AIDS. The discussion draft we'll review today makes some important changes that will strengthen the Ryan White Care Act. And I'm proud that the HIV and AIDS care community of Ohio supports this legislation and the discussion draft. I look forward to the testimony. I thank all of you who are here and for the work not only that you're here to do in this committee room, but I know that you're doing throughout our communities and our country. And I yield back.
Thank you. Gentleman from Georgia, Mr. Barrow.
I thank the chair. I'll waive an opening.
Thank you. The gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman, and thank you in particular, Chairman Pallone, for turning to the Ryan White Care Act as soon as we got back, as you promised in July. This is too important a program to get lost as we battle for health care reform. The September deadline looms large, and we have to act. Without action before the end of this month, this program, which has been a real lifeline to so many individuals and families in my district and all across our country, would be lost entirely, and that cannot happen. But what then? I would have preferred to do a continuing resolution that would take us into mid-next year and then do a more thorough job of reauthorizing the Act in 2010. There are important decisions and changes to be made to ensure that the benefits of this program reach those most in need and that it's adequately funded. In recent years, programs have been scraping by. ADAP waiting lists have left too many without care, and minority communities have not been developing the capacity we envisioned when we created the Minority AIDS Initiative. I also feel that there's some stakeholders who have not been adequately heard from. But the Ryan White program is also too important a program to allow it to become a political football in an election year. So after we protect the program from being eliminated, as per the sunset clause that was included in the last authorization, we will probably just have to kick the ball down the road a little longer just to keep the program on life support. But, Mr. Chair and colleagues, I hope that this is the last time that we do this because we don't have adequate data, because reporting systems are not mature enough, or because we're afraid to make the tough decisions to redirect the funding where it's most needed. Before I close, I want to remind everyone that people of color are 71% of new AIDS cases and 67% of people living with HIV and AIDS, that African Americans are the hardest hit, and African American women in particular. And so addressing these vulnerable populations must be a central part of Ryan White moving forward. This means a strong minority AIDS initiative that provides not only adequate resources, but technical assistance and a return to its original intent of building capacity. We also need to address the exploding numbers of hepatitis B and C infections and to do more to stem the spread of HIV infections in incarcerated populations and from ex-offenders into their home communities. I'd like to welcome and thank our witnesses today. I hope that we can fit in a follow-up hearing where we can hear from some of the communities most affected by AIDS and the organizations that have been working to serve them. And I yield back the balance of my time.
Thank you. Gentleman from Connecticut, Mr. Murphy.
Thank you, Mr. Chairman, for holding today's hearing on this discussion draft, and thank you so much to the numbers of advocates, people living with HIV/AIDS, people caring for them that are here. You know, it wasn't so long ago where people that were living with the disease, people that were caring for those that had the disease felt pressure to live that life and do that work in the shadows. And it says a lot about this Congress and this country and this society that you now are at the forefront of advocating for a strong reauthorization of this law. In Connecticut, this program just has been critical to providing low-income individuals with the medical and support services that they need. And without this funding, millions of Americans and thousands of my constituents would struggle to find that cutting-edge medical service that has been increasingly successful in treating the disease. But to say that the transition through the last reauthorization of the program in Connecticut has been rocky would be an understatement. Since the 2006 reauthorization, the Connecticut delegation and those responsible for administering the program in the state have gone round and round with HRSA and the court system to ensure that the state's largest communities, in particular New Haven and Hartford, which both actually exist outside of my district, receive adequate funds through the program and were treated fairly through the interpretation of the law. The resulting congressional and legal battles have resulted in favorable treatment for Connecticut, but I'm sure it's the preference of everyone involved to ensure that this current reauthorization does not result in the battles of the last 3 years being played out again in Connecticut or in California or in other parts across this country. That's why, along with Representative Eshoo and others on this committee, I'm encouraged that the draft legislation provides for the continuation and expansion of the law's hold harmless provisions, while addressing once and for all the need for continued stop-loss funding for jurisdictions that without it could face significant yearly funding decreases. Mr. Chairman, I'm thrilled that we haven't wasted 24 hours on our return to Washington in getting started with this authorization, this reauthorization. I'm pleased to be here for this hearing and look forward to the testimony of our witnesses. I yield back.
Thank you. The ranking member of our full committee, Mr. Barton.
Well, thank you, Mr. Chairman. I'm glad that you're still doing opening statements. I'm going to submit my formal statement for the record, just make a few remarks. First of all, I'm glad that you're holding this hearing. Congressman Deal and myself brought up the Ryan White Reauthorization Act in the markup on the health care bill back in August. And you and Chairman Waxman said that it was something that needed to be done. And here we are. So that's good. We've looked at the draft bill. There are some good things in the bill. We like the fact that it's a 3-year reauthorization. That's a good thing. That it's not open-ended. There's some bad things. Some things, you know, the fact that it is open-ended in terms of the appropriation, some of the grandfathering provisions. But having a bill before us, having a legislative hearing, being willing to do this, are all good signs. Even though this is an opening statement, my question to you, Mr. Chairman, do you plan and Chairman Waxman plan on moving a bill fairly quickly, or is this more of a get input hearing?
We do plan to move a bill, but not before we get more input from you, from the Republicans, and also from the Senate. But we realize that we have this, October 1st deadline, so we'd like to move quickly.
Okay. Thank you, Mr. Chairman, and I think I can speak for all the members of the minority. We are very willing to work in an expedited time frame. We do hope it is an open process, and we are allowed to input into the system before the decisions are made. Thank you, Mr. Chairman.
Thank you, and I think that concludes our opening statements, so we'll move now to our witness. If you'd come forward, we have one witness on our first panel, who is Dr. Mary Wakefield, who is Administrator for the Office of the Administrator, the Health Resources and Services Administration. Did I get that right? Okay. Okay, and the second person is just there to help, not to testify, I understand. We, as you know, have 5-minute opening statements. They become part of the record, and so I would now recognize you for 5 minutes. Thank you. Is the mic on? I think you got to press the button there.
Thank you.
Good.
All right. Mr. Chairman, members of the committee, thank you for the opportunity to appear before you today to address reauthorization of the Ryan White HIV/AIDS program administered by the Health Resources and Services Administration within the Department of Health and Human Services. In addition, I would like to thank the chairman, members of the committee, and their staffs for all of the hard work on this very important legislation. Let me start by expressing the administration's strong support for continuation of the Ryan White program and its reauthorization. It is a key component of our nation's fight against HIV/AIDS. Before I begin my testimony, I would like to announce that today the Center for Medicare and Medicaid Services has released a new proposal to cover voluntary HIV infection screening for Medicare beneficiaries who are at risk for infection and for women who are pregnant. Today's proposed decision would allow high-risk Medicare beneficiaries to learn of their HIV status anytime by requesting an HIV screening test and, if necessary, seek appropriate counseling and therapy. I know you'll look forward to hearing more about this new plan in the weeks to come as CMS accepts public comments and issues its final coverage decision. The Department of Health and Human Services is committed to helping promote the President's strategy to bring an end to the domestic HIV epidemic in this country. And this new proposal will allow those who may be at risk of infection to find out quickly and early so that they can start getting treatment. Ryan White provides critical medical care and support services to uninsured, underinsured, and low-income people living with HIV/AIDS who have no other source of care. Through HRSA's HIV/AIDS Bureau, grants are awarded to cities, states, and local community-based organizations for the purpose of providing primary medical care and support services to individuals living with HIV/AIDS. I saw this firsthand on my very first site visits as administrator to Ryan White grantees in Chicago and Philadelphia. There I observed the difference these programs make in patients' lives. With this in mind, I would like to talk broadly about the administration's vision for reauthorizing this program. Since its inception in 1990, the Ryan White program has been providing HIV-related care to a growing number of infected individuals. This year, approximately 529,000 individuals will receive Ryan White services. The program consists of Parts A, B, C, D, and F, which are differentiated by the types of services rendered and/or by the entities receiving funding. HRSA recommends a 4-year reauthorization to minimize disruption of funding and services for grantees and clients, and to permit time for the implementation of healthcare reform policies and programs to examine the impact on Ryan White. The administration would also support a 3-year reauthorization consistent with the draft House bill. In addition, HRSA supports the language proposed in the Energy and Commerce draft legislation to eliminate the repeal language that was part of the last reauthorization. Presently, Parts A and B grantees are subject to 3 different penalties if they have unused funds remaining by the end of the grant year. First, barring a waiver for formula funds, grantees must return any unspent formula and supplemental funds to HRSA at the end of the grant year. Second, grantees with more than 2% of unobligated formula funds at the end of the grant year will receive a reduction in their subsequent grant. Third, grantees with more than 2% of unobligated formula funds cannot apply for supplemental funds for the subsequent grant year. HRSA encourages amending these penalties for Parts A and B grantees because of the financial and administrative burden it places on them. HRSA suggests eliminating the penalty that requires a decrease in a grantee's subsequent grant award by an amount equal to the unobligated balance remaining from the current year's award. The elimination of this provision helps to ensure that grantees will have sufficient funds so they will not have to interrupt service to individuals living with HIV/AIDS. In addition, HRSA recommends raising the threshold from 2% to 5% for the penalty that prevents grantees from receiving supplemental funds when they have unobligated formula funds. Both of these provisions are contained in the committee's current draft, and we are appreciative of their inclusion. HRSA also suggests offsetting future year awards for grants with unobligated balances as opposed to cancellation of the amount. The change from a deobligation to an offset would retain the intent of the law while simplifying penalty administration and expediting the redistribution of funds to other grantees to provide HIV/AIDS care. HRSA supports eliminating the distinction between EMAs and TGAs under Part A. HRSA proposes designating Part A grantees as EMAs when those grantees have greater than or equal to 1,000 cases of AIDS during the most recent period of 5 calendar years for which such data are available. By eliminating the EMA-TGA distinction, the appropriation for Part A could be distributed proportionally across all highly impacted jurisdictions based on the number of living HIV/AIDS cases. This suggestion is supported by Energy and Commerce's draft legislation. Moreover, for the transition grant areas that are at risk of losing TGA status in future fiscal years, HRSA supports efforts to maintain Part A award levels so that important HIV/AIDS services in those jurisdictions are not interrupted. This recommendation is reflected in the Energy and Commerce draft legislation. 6 transitional grant areas are at risk of losing their status under Part A in fiscal year 2011 due to their inability to meet the definition of a TGA based on AIDS case counts. HRSA is eager to work with you to resolve this issue. We are over a quarter century into the HIV/AIDS epidemic. With my background as a nurse and as a nurse educator, I know how important it is for us to train a new cadre of HIV health professionals to replace the first wave of experts that are nearing retirement. We also need a new generation of healthcare workers to meet the difficult clinical challenges that are emerging in a world where HIV infection, with treatment, is managed as a chronic condition. HRSA suggests implementing a program for ATC participants that provides training of sufficient duration to ensure that new health professionals are appropriately trained to provide HIV care and are strategically placed in areas with high need of HIV medical care. Finally, HRSA proposes to permit additional time for code-based reporting states to transition to name-based reporting systems for living HIV/AIDS counts, upon which funding is based. Under current law, the exception for code-based reporting will expire at the end of fiscal year 2009, and as of fiscal year 2010, all jurisdictions must report name-based data. 9 jurisdictions are still in the process of converting to name-based reporting systems. Without an extension, these code-based reporting states will be unable to receive funding after fiscal year 2009, which will disrupt services to patients with HIV/AIDS in those areas. We are appreciative of this being included in the draft legislation. In summary, I want to acknowledge the dedication of the advocacy community, its work on the consensus document, and its incredible commitment to those individuals with HIV/AIDS. The Obama administration is committed to working with you, with Congress, to reauthorize the Ryan White program and to ensure that critical services continue beyond September 30th, 2009. I would be pleased to answer any questions you might have concerning the reauthorization of Ryan White HIV/AIDS program. Thank you.
Thank you, Doctor. We're going to have questions from the members of the committee. Basically, we allow 5 minutes for each member. I was going to recognize myself initially. The Ryan White program is one that OMB has rated as highly effective, and I'm sure HRSA will continue its good work in administering it, and I want to thank you for that. You said that the administration supports at least a 3-year extension. I think you actually mentioned 4, but you could live with 3. Would you tell us why that's the case? In other words, what would be the impact on grantees if we only had a shorter extension, 1 or 2 years? Why are you saying 3 or 4?
We're asking for a longer reauthorization because we think that it will provide greater stability for the program, and it would also provide us with additional time to evaluate the impact of changes that might be made to the program, and so those changes that would be affecting grantees. Also, we would have, with that additional time, more mature names-based surveillance systems in place and time to evaluate the impact of healthcare reform policies and programs and their implications for Ryan White.
Okay, well, my second question is about this code-based versus name-based. I know you mentioned it several times there towards the end of your testimony. CDC's recommendation to the states is that they collect surveillance data from the states on a confidential names-based basis. But today all states are in fact collecting names-based data, but their systems are at different stages, as you mentioned. Some have been collecting names-based data for enough years that CDC has deemed their systems mature. Others are still transitioning from earlier code-based systems. Now, under the current law, states can still report code-based data if their names-based system isn't fully ready to accurately reflect HIV in the state. But how does HRSA account for the fact that code-based data may contain redundancies?
Well, you're right. There are redundancies in code-based data. And so the way that's accounted for is through a 5% reduction that's taken in the counts of the cases. So taken in case counts that are reported from code-based systems. So 5% reduction taken in case counts that are reported through code-based systems.
Is there any other penalty other than with regard to these code-based states?
Yes, there is a 5% cap on the increase of a grant award for subsequent grant awards. So, yes.
Now, have these penalties actually been applied to states that are still reporting, some of the HIV cases as code-based?
Yes, sir, they have.
And, I mean, I understand that the penalties help motivate states as they transition to the name-based reporting, and so that's why you have them. Now, the discussion draft would maintain current law for code-based reporting so that states continuing their progress to name-based reporting, would still be able to progress. But is it your understanding that the 8 jurisdictions still using the code-based reporting are making enough progress towards this fully name-based system, or should we be doing something else to encourage it?
We believe that all states that are still operating with code-based are making the necessary changes and have a commitment to transition fully to names-based reporting. And as you indicated, their systems are still in a process of maturing, and those jurisdictions are at different places in the evolution of their systems. But yes, we're in contact with them, and we feel that they have a commitment to continuing forward.
And then so you want to continue this policy of having certain penalties, but still allowing them to use the old system at least temporarily.
Yes, that's correct.
Okay. Now, I don't think you mentioned the severity of need index. I wanted to mention that. One of the recommendations from the community consensus, and it's also in the discussion draft, is to clarify that HRSA should not yet begin implementation of the severity of need index. The 2006 reauthorization required HRSA to develop an index that could allow for distribution of funds based on concrete factors reflecting need. But tell me a little more about this index. I know you didn't mention it, but I'd like to know, what the idea is.
So in terms of the severity of need index, supplemental grants under Parts A and B are awarded to areas and states that submit applications based on the need in the area or state on an objective and quantified basis. Currently, jurisdictions submit applications that are scored through an objective review process to determine level of need and subsequent funding. At Congress's direction, HRSA contracted with an organization to establish an HIV/AIDS severity of need collaboration to develop this index that you're referencing. The collaboration was comprised of a multi-tiered expert body broadly representative of HHS, HRSA staff, national experts, Ryan White program grantees, and consumers. Based on the Institute of Medicine's recommendations, there were four expert panels that were convened to identify relevant data sources and measures that demonstrate needs in terms of area characteristics, patient coverage and need, associated costs, and so on. The panels then prepared written reports reviewing more than 56 variables and forwarded 19 for inclusion in a draft severity of need index. Some of the 19 remaining variables were eliminated for reasons such as lack of uniformly highly quality data at the state level. HRSA and our team that we contracted with has analyzed the recommendations of the panels, completed supplemental studies, and developed a draft model of severity of need index to be applied. The index uses data measures comparable across jurisdictions and is based on quantitative measures established from existing national data sources. We've also, in 2008, contracted to conduct an independent analysis of that methodology, and the independent evaluators concluded that the process that was used to develop that severity of need index was comprehensive, but some elements of the formulation failed to meet their intended purposes, so that the index from that perspective might be modified to better distribute supplemental funding based on need. The status of the severity of illness index at this point, well, the 2007 and 2008 reports are in clearance in the department, and we are working to get those reports to you as soon as possible.
Okay, thank you very much. Mr. Whitfield.
Dr. Wakefield, thanks for being with us today, and we appreciate your input. In your opening statement, you mentioned that there is an HIV epidemic in the country today. And what is the definition of an epidemic, and is there a certain number of cases that you must have to be called an epidemic? Would you just clarify that for me, what that means?
Applied here, it's referring to, for us, the care that we provide of over 529,000 individuals served through our Ryan White AIDS program.
So if it's over 500,000, it's an epidemic?
And greater than 1 million diagnosed with HIV/AIDS in the United States.
So in the United States today, there are over 1 million people that have been diagnosed with AIDS?
With HIV or AIDS,
yeah.
Yes.
I was just reading this Kaiser report on the HIV program, and it indicated that this number of 500,000 being treated really cannot be totally verified because it may be duplicative. And it says specifically that there is no client-level data collection system. Is that true, or is that not true?
There are duplicate numbers that we try to account for in our funding allocation. Do we have the specifics there? I could give you the, so yes, we know that there is some duplication. We do have strategies for trying to correct that duplication.
But is it true that there is no client-level data collection system?
Oh, we have,
to help you out a little bit here, I was reading from the Henry Kaiser Family Foundation HIV/AIDS policy fact sheet. It says, although it is not possible to obtain an unduplicated count of clients because there is currently no client-level data collection system.
Starting in June, all right? Yeah, excuse me. We do have client-level data that we are collecting and have available now, but just effective as about June of this year.
So it went into effect June of this year?
Just in the last few months, that's correct.
And that would be nationwide and in the 9 territories?
Yes, sir.
So,
but it's just within the last few months.
Okay, but it is in effect now, so we'll be able to have a more accurate number.
Yes, that's correct, going forward.
Okay. Now, in the transitional grant area proposal, in the discussion draft, they're talking about the 6 transitional grant areas that they're asking that they be grandfathered. Now, I'm certainly not an expert in the Ryan White Act, but it's my understanding that in order to obtain a grant, you have to meet certain criteria, like so many thousand cases and whatever, which is the way it should be done, because with limited dollars, you want to go where it's most needed. So it would seem to me that if you just automatically grandfather 6 areas because they've had them the last 3 years, that you might be overlooking or underserving other areas that may need it even worse than those 6. Do you have any comment on that?
We do support continuation of those 6, primarily to avoid disruption in services for the individuals currently being served, and also so that there isn't an undue burden on areas that might be geographically located next to those 6 areas.
But, you know, I guess since Ryan White was authorized first in 1990, there's always been this process that a 3-year grant period, and then it would be reevaluated. So that doesn't concern you then that other areas may be underserved because you're going to allow these to be grandfathered?
We are supportive of continuing the inclusion of those 6 areas.
Okay.
Yes.
Now, President Obama, like all of us, has expressed great concern about the federal debt that we have today and the impact that that will have on our country. And I would just ask you, this legislation also provides open-ended appropriation, such sums as necessary. And there's been a growth in this program from $200 million to about $2.3 billion. Do you think it's necessary to just have an open-ended such sums as necessary, considering the current financial situation we find ourselves in this country?
HHS does support the inclusion of the wording such sums as necessary for subsequent years, for subsequent fiscal years for each part of the Act. So, yes, we do support.
So you do support it. See, my time's expired.
Ms. Capps.
Thank you very much, Dr. Wakefield. I have a couple questions for you during my time. One is to share with you my concern to learn that the Centers for Disease Control and Prevention, CDC, estimates that the number of births to women living with HIV has increased approximately 30% from 2000 to 2006. There are all kinds of new phenomena arising within this area of HIV/AIDS, chronic length of living with the disease, and a whole new raft of issues that need to be addressed. I'm sure you are considering this something that needs to be dealt with as well. Do you have any ideas or plans in place to address the needs of women and children and families in light of the growing numbers of HIV-positive women of childbearing age? Perhaps you can discuss, if you will, how Part D of the legislation will help to ensure that their needs are met.
Well, you're right. Part D is the part of the Ryan White program that is probably most targeted toward exactly the population of which you are concerned. It, of course, allocates funds through public and private organizations, community-based organizations, states and universities, and it can provide outpatient or ambulatory care directly to or through contracts that are awarded. It is really designed to serve women, infants, children living with HIV/AIDS support and provide support services to those individuals. That's really its key target population. We also have resources that are available through Part F, the SPINS program. It's referred to a shorthand, that can be allocated to direct research and other activities to particular target populations. So that's another vehicle that I think it's safe to say could be added. Beyond that, Parts A, Parts B, and C also provide care to the population that you've just expressed concern. But as you indicated, Part D is really targeted to, as mentioned, women, infants, children, young adults.
Thank you. And part of our goal then, in our communities especially, is to identify and encourage people to get tested so that they can understand that they are and that they can get into some of these programs and being able to deal with it early on. To that, topic. I'm concerned, you heard in several opening statements about the impact of several of our state budgets on the ability to care for HIV and AIDS patients. I've heard just horrendous stories in my district in California about matters of life and death, really, if our state budget is going to cut so drastically the services on which people really depend for their care. They're going to have to choose between their medicine and their food. I mean, I'm sure it's not just confined to my district. I can see people in your audience nodding. And I know this is a story across the country now. How can we respond? How can HRSA respond to work with some of our states where this is such a huge challenge right now?
Well, you're right. We've been hearing from a number of states about the challenges that they're facing locally. And certainly California is one of those states that we're trying to monitor and work with as closely as possible. On the front end, the administration, of course, strongly supports continuation of this program, first and foremost, to provide vital funding to states and cities to provide services to people living with HIV/AIDS. In part, perhaps, to address your question, it might be useful for you to know, too, that the President's fiscal year 2010 budget request asks for an increase of about $53.9 million over the fiscal year 2009 omnibus level. That funding would continue to support over 2,300 providers that would help 500,000 individuals living with HIV/AIDS obtain access to life-sustaining care and services. So, in fact, there is an additional request, a request for additional funding, I should say, that should help to mitigate a bit of those concerns. But bottom line, we are aware of that and working as closely as we can with jurisdictions and states that are feeling particular pressure to maintain their services to this very vulnerable population.
Well, you can be assured that there are many members of our Congress, and including in this committee, who will seek to look for further funds if that is necessary as we see some of these state budgets unfold. I don't think it's really hit yet as hard as we're going to see in the coming months, where we are really facing in our communities. It's not just this population, unfortunately, but this is one that is clearly made itself known to me, and I know my colleagues will share in wanting to help you with if there's any emergency funding that can be made available. And surely the increase in the budget for next year is going to be something. It was intended, I'm sure, to expand services, but at least it will provide that stopgap, hopefully, for some of the states where the bottom's falling out. And I appreciate your awareness of and concern for this situation.
Again, and we are aware, we are concerned, and we have been trying to collect data, or information at least, anecdotally from our contacts in each of the states. So we've got a little bit of a litmus test about how things are going at the state level. We'll continue to try and do that and then share that information as
We'll encourage them locally to reach out to you, let you know what the status is. Thank you. Thank you, Mr. Chairman.
Thank you. Ranking Member, Mr. Barton.
Thank you, Mr. Chairman. I don't think I'll take up my full 5 minutes. Dr. Wakefield, I'm assuming that you're here as the official representative of the Obama administration. Is that correct?
I am here representing the administration.
Okay, so you speak for them.
Are you inquiring, sir, about whether or not the testimony is...
Well, I'm just saying if you give an answer and I like it, I can depend that that's the position of the Obama administration.
Well, I don't know if I can know it.
And
I'm speaking as the HRSA administrator, but the testimony that I've shared with you has been developed and reviewed.
Well, sometimes in both administrations, Republican and Democrat, we have officials come and when we ask them if they're on the record for the administration, they hem and haw and then say that it's their personal position. And so I'm not being devious. I'm glad the chairman's holding the hearing, and I'm glad you're here. But as a senior Republican, I want to ask some pretty straight questions. And if you give straight answers, I want to know that that's where the Obama position is. That's all.
And if I might, I guess what I would add on the hemming and hawing part, what I would add is that it is, of course, a normal protocol in either administration for the administrations to release their official statement of administration policy at some point between committee hearings and markup and floor action. So that's the
Well,
venue for that official
I think
position.
we've spent a minute and a half of my time
Sorry.
hemming and hawing already, so you're already right at the top of the list in being able to do the Texas two-step. I'm in awe of your ability to say nothing by
I went to
smiling.
school at the University of Texas at Austin. So
I knew that. My wife did too, so
Okay.
we're a mixed marriage. Anyway, let me ask the first question. Now, this is an authorizing committee. We try to set the policy and set the provisions, and then we pass it over to the appropriation committee, and they're supposed to implement by passing funding bills that do what we say. This draft, one of the problems that the Republicans have is that it uses the term such sums, and Mr. Whitfield has already discussed that. Does the Obama administration have a problem in working with the chairman and the ranking members on the Republican side before this bill is marked up to change that language from such sums to specific sums that everybody agrees are appropriate? And I don't think we have a huge difference in funding priorities. At least if we do, I'm not aware of it. But
we don't oppose such sums, but we'd be happy to work with the committee going forward.
well, we want, and again, I think even my distinguished chairman, Mr. Waxman, and the subcommittee chairman would agree that if we can agree on what that amount should be, it's better from our committee perspective to tell the appropriators where to spend the money. So so you're willing to work with...
We will work with you, sir.
Not just with me, but also with Mr. Pallone and Mr. Waxman. So it's, I might point out that if we had the vote right now, my side would win. We've got 5 and they've got 2, but they probably have 7 out in the annex eating pizza, so they'd probably bring them in. My second, and here's Mr. Whitfield talked about this. The provision in the draft bill that grandfathers the transitional grant areas. First, we don't have a problem with there being transitional grants, and we don't have a problem that those be authorized an additional 3 years. Our problem is, if we're really trying to solve the problem of helping those families and individuals that have AIDS, that population does change over time, and its location changes over time. We would like to have some ability to move the money where the people are that still need assistance, as opposed to where they may have been in the past. So we're not opposing transitional grants. We're not even really totally opposing the grandfathering, but we would like to work again with Mr. Waxman and Mr. Pallone and others on the majority with the Obama administration to see if we couldn't move some of those grants into areas where there is more need today. And that's, I think, what Mr. Whitfield was trying to get at. Do you have an opposition to at least discussing that issue?
I would say that we share and are concerned about ensuring that there is stability of infrastructure to meet the needs of individuals with HIV/AIDS. So that's our very first priority, to make sure that there isn't disruption in availability of care to those populations.
I understand that. Well, Mr. Chairman, my time has expired. We fully, so I want to really emphasize this. I was chairman when we passed the last reauthorization bill in 2006, and I was very proud that that was one of the things that we did during my chairmanship. I'm very glad that you and Mr. Waxman are trying to do a reauthorization bill. The Republicans really want to work to make that happen. We feel it is important from a committee perspective and from a policy perspective that we continue to have this bill in law, not in some appropriation rider that's year to year. And we also agree that as the need changes and the location changes, we need to update the bill, so update the law. We hope that we can do that in a very timely fashion. and move this bill on a bipartisan basis. And with that, I yield back, Mr. Chairman.
Thank you, Mr. Barton. Mr. Sarbanes.
Thank you, Mr. Chairman. I just had a couple questions. First off, can you just be a little more specific about what it means to not yet be mature in this transition from code-based reporting to name-based reporting? I mean, what does that actually reflect?
So you'll correct me if I'm wrong about this. So for example, some states have had statutes at the state level that, for different reasons, had to be addressed in order for them to be able to produce these data. So that's one potential problem that's affected some states. Every state has its own set of circumstances in terms of being able to collect that information and aggregate it and make it available. So the process is really varying on a state-by-state basis. Data are collected from different sources, and as I mentioned, there isn't any one uniform pattern that was established initially that they're all working from in terms of reporting those data. I mean, there's just a challenge of getting all of the people that have HIV reported by name. And as I said, states have in some cases better circumstances in collecting that information, and other state circumstances not as much infrastructure initially to be able to collect that data. So it really has been a fair variation state by state.
And typically the range in terms of making this transition on a time basis has been 2-3 years is what it's taking people to, or
probably a little bit longer than that, more like a 3 to 5 year period of time to make the transition.
Okay. Yeah. Okay. The other question I had is I was looking at some of the statistics in terms of the Ryan White program serving 500,000 people across the country, of which 33% are uninsured and 56% are underinsured. And there's been some allusion, of course, as there would be, to the fact that we're wrestling here with a larger health insurance reform effort, where we would hope that we would get to a place where there's much broader coverage available to people. We don't have the same numbers of either uninsured or underinsured people. But I also anticipate that we shouldn't fall into the trap of thinking that because we will find ways of providing better coverage going forward for the whole population of the country, including those who live with HIV and AIDS, that somehow there'll be some kind of one-for-one corollary in terms of reducing the support that exists through this program. And so I wonder if you could speak to the fact, as I see it, that so much of what makes this successful is that it is approached from a public health, from sort of the public health standpoint, with resources flowing to collaborative networks that exist in states and at the community level, and that kind of infrastructure support needs to continue regardless of what the individual coverage status is that a particular person may have. So if you could just speak to that.
The Ryan White HIV/AIDS program does fill really significant gaps currently, and it provides critical capacity to reach underserved populations, the very people that you were just describing, percentages of uninsured and underinsured. And currently about 72% of the individuals who are served, for example, are below the poverty level. The administration believes that the Ryan White HIV/AIDS program will continue to play a vital role after healthcare reform is enacted. For example, because of some of the services that are provided through it, services such as medical transportation, nutrition services, case management services that are part of the, not the core services, part of Ryan White, but rather the support services for which resources are currently allocated and used across the country, casting this, just as you indicated, as a broader public health community approach to care.
Thank you. I mean, I guess I'm just trying to make the point that there's a, and it's really the case management side of things, the dimension to what is offered through these resources that will continue to be absolutely critical, even if an individual now has access to insurance coverage through more conventional means as a result of some of the reforms we put in place. If we don't bring this other lens to the table and continue to sustain it, then many of the gains we're trying to make will be lost. So I appreciate your testimony on that and yield back my time.
Thank you. Mr. Burgess.
Thank you, Mr. Chairman. Dr. Wakefield, thank you for being here today. I'm going to ask you a question that Chairman Pallone already asked you, and I'm a little scared to do it because I didn't understand the answer you gave him. So I'm hoping you will give us the translation. When you talked about the severity of need index, you gave a very complex answer. But can you tell us just what that means to our districts and our constituents? What that means to the folks back home?
Right now, that the data associated with the severity of need index is on our website. So your folks back home could actually take a look at how the data are collected and what they're displaying. So that information is accessible that way. Our formal report to you, however, is still in process, and as I mentioned, we hope to get that to you shortly.
So what is the practical implication for the folks back home? They go to the website, they check out the data. Are there, in fact, additional funds that they could plus up with now, or is that awaiting your report back to us?
That's correct. Waiting. There are not dollars associated with this at this point in time.
Thank you. That's helpful. You also talked a little bit about moving from a palliative care model to a chronic care model. Can you briefly just explain what that will look like?
Sure. The reference is really a bit more about where we have come from in terms of the treatment of HIV/AIDS, moving from a time when we didn't have the available drugs, pharmaceuticals to treat and extend the lives of individuals. So we're at a very different place currently. In terms of treatment of care of patients than we were when this epidemic first began and as it developed.
Correct. And is that likely to affect your funding model? Because clearly now the emphasis is much more on the life-extending drugs and the disease management drugs that are available, but also happen to be fairly expensive and come with some other costs with side effects and that sort of thing.
Yes, and so we have grantees that request funding to be able to deliver services using a chronic care model through case management and so on.
Now, is that in widespread usage throughout all of the communities?
It is. Yes, I mean, in terms of how grantees are working to deliver care to patients, right now what we are seeing in terms of allocation of funding is more dollars available, for example, for drug therapy, pharmaceuticals, and less money having to be devoted, for example, to hospice care. So that would be an example of a change in...
Okay. And you did make the statement at one point that your first priority is the stability of infrastructure. And I just wanted to be clear, really our first priority is treating patients. And if treating patients is providing them with the therapeutic cocktails they need to extend their lives and minimize their symptoms, that should be our first priority.
Absolutely.
Let me ask you a question. I actually may be very brief. I may submit this in writing. You just referenced healthcare workforce, which is extremely important to me. As I recall from our previous work on reauthorization of Ryan White, there's not really healthcare workforce is not really specifically addressed in the bill.
Well,
that comes in other parts of what we're doing. Is that not correct?
Well, their healthcare workforce is addressed a bit through Part F, for example, through the education training centers that exist and can provide at least short-term information to healthcare providers to help them deliver healthcare services. So we do have funding that goes to universities, for example. I believe about 11 of them. 11 education training centers to help with at least short-term training of HIV/AIDS healthcare providers. That is what exists currently.
Okay. And again, I may submit some additional questions about that in writing to you. Let me just briefly reference Dr. Christensen referenced incarcerated populations, and we have a significant problem with in our area back in Fort Worth with people who have spent time in prison, come back with a new diagnosis and may in fact bring that illness back with them to their homes when they are re-entered into society. What are is there anything over the horizon that you're looking at in being able to capture these problems when the person is incarcerated, and then an educational way to help mitigate that problem as they come back into the community?
We have some of our HIV/AIDS clinics that do pay special attention to the very population that you're describing right now. We also are looking at supporting models of care that target the population moving from incarceration and back into community. And we have a particular initiative that focuses explicitly in that area that is ongoing now. Don't have results I could report to you at this point, but it is ongoing.
Again, we may submit something in writing to you on that. And then just finally, who's the head of Center for Medicare and Medicaid Services currently?
We have an acting head.
Is that a problem?
I enjoy really very good relationships with my CMS colleagues. I haven't had any difficulties in terms of my meeting my information needs.
When you visit back with the administration, we would benefit, I think, from having a full-time administrator. That is, after all, the largest insurance company on the face of the earth, and they need a full-time CEO. I'll yield back, Mr. Chairman.
Ms. Christensen.
Thank you, Mr. Chairman, and welcome, Dr. Wakefield. We welcome your experience and your expertise that you're bringing to the office. As I said in my opening statement, many of us are concerned that the Minority AIDS Initiative was never really allowed to live up to its objective of creating the local infrastructure in minority communities, and Dr. Parham has been through this with us since its inception. And then changes were made that made it hard for these small organizations to compete for funding. They've been assessed on outcomes that were really not appropriate for what they were being asked to do. And given that the hardest hit communities remain those of color, and I quoted 71% of new AIDS cases and 67% of people living with AIDS are people of color, what do you envision, what would you recommend from the perspective of the HRSA administrator to ease the existing disparities, particularly among communities of color, and what do you envision as perhaps a larger role for the one and only National Minority AIDS Education and Training Center, which is doing great work but with a lot of limitations?
We're very supportive of our training centers, including the one that you reference, and we are also supportive in terms of preparing the next generation of healthcare providers of additional resources going to those training centers to provide for education and training over a longer period of time so that our next generation of healthcare providers can meet the needs of the population that's affected. And as you indicated, we have a high proportion of individuals, of minorities who are HIV/AIDS infected. So that is a concern for us, and we look to our training centers, as you indicated, to be supportive in terms of preparing healthcare providers to better meet those healthcare needs. We also, of course, have the Minority AIDS Initiative, and that is threaded through various parts of the Ryan White CARE Act. And provides resources and services for the particular population of which you have expressed your personal concern.
Our intention originally was that the organizations from within that community would be helped to build capacity, to develop the capacity, and that really didn't happen. Are you in favor of building capacity from within the communities rather than bringing organizations from outside to work with the communities? Do you tend to the side of having the communities build that capacity themselves? Because I think that's where we failed to, really meet the goals.
Well, there are pieces, of course, of Ryan White that really allow for local community input about strategies that might be best aligned to meet the needs of the individuals in their communities. So as the program is currently deployed, not everything, of course, is dictated from the federal level, but rather we work with potential grantees when they submit, for example, proposals for supplemental funding, and they identify locally what their priority needs might be for the populations that they serve. I think that's very important, that we listen to local communities and that we are receptive to the strategies that they're recommending about how to best meet their community's needs.
Okay. Well, I'm sure, particularly the Congressional Black Caucus, which was instrumental in getting this started, would be interested in sitting down and discussing this with you further. On the whole harmless proposal in the consensus document, I tend to agree with the minority position, which says that, which agrees that in 2010, it should be set at no less than 95% of funding for 2009, but disagrees on 2011 and 2012. This group would like to see the formula funding for Parts A and B better match the number of HIV and AIDS cases in each jurisdiction, rather than staying at the 100%. And it just seems to me, and wouldn't you agree that following what the minority view is suggested, and these are places like the Southern AIDS Coalition that is where represents a part of the country where which is becoming the epicenter of this disease, but wouldn't you agree that their proposal would be a better way of ensuring that the funding followed the epidemic?
HRSA recommends that we continue hold harmless provisions for Part A and Part B grantees. We will, of course, look and provide technical assistance as you make determinations about what more specific provisions you would be interested in pursuing as a committee. We'll be happy to work with your committee staff. Program will be happy to work with your committee staff as you have different approaches to that, to hold harmless. But bottom line, we recommend continuing hold harmless provisions for both A and B.
My time is up. Thank you.
Thank you. Mr. Shimkus.
Thank you, Mr. Chairman. The benefit of the hearing process that we're going through is it helps remind us and get into more specifics than we would generally do, and that's why I like to attend them as much as I can, because I learn a ton. So excuse me if I'm asking some basic stuff. So I've got in the Ryan White programs, and I also, my first time I was really lobbied on this was a young boy in rural southern Illinois who was a hemophiliac and had a blood transfusion. He and his mom came in and said, this is an important program for us. And so that's why I think there really is bipartisan support. So you got Part A, based upon HIV and AIDS cases. You got Part B, which is a supplemental based upon formulas of more crises in an area. Is that correct? Or you want to impact more money sooner rather than later?
Part B for states and territories and emerging communities.
Right.
So communities that might have a smaller number of cases but look like they might be increasing. Also, in addition to, I think you mentioned maybe some discretionary funding in Part B. True. Supplemental funding, that might have been the term. There also is base or formula funds associated with Part B as well. So it has a formula component. It also has a supplemental component.
And then Part C goes to early intervention clinics.
Yes, that's correct.
And that, have we been able to do, obviously, we all know that education is a key to helping address and solve and mitigate healthcare risk across the board, whether it's HIV/AIDS or whether it's H1N1 or whatever else, and that's really an important critical aspect. Do we see in the early intervention clinics, is that has an educational component, or is that like the first stop for someone who is their first stop where they figure out they've got something wrong, and the clinic is their first
For
stop.
Part C? For Part C,
Right.
you're asking about, so that's discretionary funding, and that provides core medical and support services to people who are living with HIV/AIDS now, and so to folks in the service areas for those community organizations.
And D is women, the family component, which is women, infant, children, and students. Another formula-based.
No, that one is discretionary.
And it's based
but-
upon what? I mean, you all have the discretion, obviously, but what are some of the parameters that you use?
Sure. So individuals or organizations, I should say, apply for funding.
It's a granting process.
Yeah, exactly. Correct. Yeah.
And then the F, which it took me a while to figure out that this was all part of F. You have the dental, which I think is easy to understand, and the A.A.H.I.V.S. and the SPNS, and I found out where that was. They are the Special Projects of National Significance. It's another grant program.
That's correct.
And then the MAI is Minority AIDS Initiative, which I think Representative Christensen has just elaborated the importance of that. And I think we all fully understand those issues. From the minority side, again, I think we would want to, we really want to encourage, because these are specific programs which have specific authorizations, hopefully based upon cases and money spent and historical aspects, and we do know population shift. This is going to be an issue of follow the money, if you haven't figured that out now, because people are going to say, okay, we've got areas that have historically been high. We don't want to disenfranchise that pool of money. I'm from Illinois. Chicago's a big area. They're always talking to me about let's don't hurt Chicago, but I'm a rural representative, so what if there is a migration into rural areas and that population shift is significant enough to start having impact. So this is, whether we like it or not, like my colleague Congresswoman Kapp said, this is really going to be a follow the money issue. So the question is on that's why these such sums as may be desired is problematic for us in a period of increasing deficits and a national debt threefold so far in this year. It's hard for us to go back to the public and say, blank check, we don't know. It would be much better if we did some analysis saying, here's the population, here's the needs, here's the amount we need. And we have historically been able to come back for supplemental requests and added money if we guess wrong, and I mean terribly wrong. But I would respectfully suggest that we go back and work with the committee to hone down a number. In this environment that we're in today, such sums as may be requested, I think is a tough one to overcome because it'll be attacked across the board. And with that, thank you, Mr. Chairman.
Gentleman from Georgia, Mr. Gingrich.
Mr. Chairman, thank you. And it's amazing how often this happens that you sit here for an hour and a half, and waiting. You've got this prize question you just cannot. You're itching to ask, and the guy or the gal just before you ask your question, and Mr. Shimkus just did that. But I think it's such a good point that I want to ask the question again. And Dr. Wakefield, first of all, let me just say thank you. I think your testimony has been very forthright and interesting and informative. But yeah, what Representative Shimkus said in regard to such sums as may be necessary, and Representative Whitfield brought it up earlier on this side in his line of questioning. And your response to that was kind of, well, the language is okay with me, rather than what I guess he hoped and what maybe Representative Shimkus and certainly myself would like to suggest is this makes it a very difficult vote for those of us on the Republican side and maybe for 52 of the majority party when we get to the floor. because of the climate that we're in, the very difficult times that this estimation of $9 trillion worth of deficit over the next 10 years and $1.8 trillion in 2009. The American people that were so fired up and feisty and in our face at these town hall meetings, it wasn't just about their concern about a government takeover of our health care system, although certainly many Medicare patients were there and concerned about cuts to Medicare. A lot of these people were outraged over the continuation from the Republican majority for 12 years and now the first 9 months of the Obama administration and the majority of Democrats over the last 2.5 years. It's just more of the same and getting worse. So the point that's been made about that, I think it should be well taken by you, and I hope it is, because if President Obama, and I truly believe he does want bipartisan support for many initiatives, and he'll talk about that, I'm sure, tonight. But if you're going to get that, don't put language like that in a bill where our constituents go nuts over that. And so, you know, to specifically say to spend a certain amount, up to a certain amount, then the appropriators can go up to that amount if they need to. And as John Shimka said, we could always come back and add if necessary. Now, let me, and I know I want you to respond, and fortunately I have a little extra time. The chairman's been generous because I didn't make an opening statement, and I'll give you sufficient time to respond. I am also concerned about this issue of this hold harmless, these jurisdictions. It would seem to me that if we got a certain amount of money to allocate for something of this importance, HIV/AIDS, and trying to to eradicate this disease in our lifetime, I hope, and to make life more palatable and tolerable, and possibly even help these patients, 500,000 or more, I think you mentioned, nationwide, to be productive citizens. God help them, and we need to help them, no question about it. But if you've got areas where the caseload is going down, and you've got other areas where the caseload is going up, you made the statement, well, you know, we've still got those infrastructure needs, and they don't go away. Well, I think they do go away, maybe not in straight line proportionality, and therefore in the districts where you're seeing more patients, I would guess that the infrastructure funding need goes up too. Maybe, again, not in a straight line, but so explain to me once again why you wouldn't want to reallocate this money and do this whole harmless deal instead, where you can only cut a maximum of 5% in year one and no cut in year two and in year three. I mean, money doesn't grow on trees, and I'm sure you would agree with that, Doctor. And so once again, if you don't mind explaining to us, why would you support something like that kind of language?
So HRSA recommends continuing hold harmless provisions for both Parts A and B grantees. The hold harmless provisions were included in the 2006 reauthorization to prevent, as you indicated, destabilization of the HIV care infrastructure, and also from significant funding shifts due to funding formula distributions from year to year. We're sensitive to the impact of funding changes on systems of care, as I indicated, and for those reasons, as well as for administrative simplification reasons, that is our recommendation. With regard to your comment about the such sums language in the legislation, HRSA will, of course, implement the program exactly the way the Congress suggests in terms of spending. We'll expend those funds to support these very critical programs. The such sums language that is included in the bill is, as I mentioned, certainly acceptable to HRSA, and we look forward to working with you to ensure that the funding that is allocated to this program meets community needs, and is judiciously spent. So those are also very important from our perspective. The community need is met, and that those resources are very judiciously spent.
Dr. Wakefield, thank you, and I'm glad you would be willing to work with us, because as I point out, I mean, this is a bill that I don't think very many members on either side of the aisle would want to be on record as voting against. But the such sums as necessary just makes it more difficult. And I think, as others have said before me, that this is certainly a time where we need to be, at the federal level, spending the taxpayers' monies. We need to be tightening our belt. I mean, you know, you look at things like a dual-engine program for the Joint Strike Fighter, and I could go on and name many things, sacred cows that we just continue to pour money into. And so if we can tighten our belts on this and be wise about how we spend the money and get the money to where it's needed in regard to these HIV/AIDS patients, rather than just continuing to support an infrastructure somewhere that has fewer and fewer patients to deal with, people may be sitting around kind of twiddling their thumbs a little bit, Doctor. You know, you may want to refute me on that, but that's my concern. It's being fiscally responsible with the American taxpayers' money. And, Mr. Chairman, I yield back.
Thank you. Gentlewoman from Colorado, Ms. Teget.
Thank you very much, Mr. Chairman. Dr. Wakefield, I just wanted to follow up. I wanted to talk to you a little bit about the policy here, and I wanted to follow up on something that Mr. Burgess brought up very briefly, and that is the need that you talk about in your testimony for the training of new HIV healthcare professionals. I'm wondering if you can describe the projections of how many new HIV health professionals we need.
I don't have numbers with me or an estimation with me. I'd be happy to go back and then provide that information for you.
That would be very, very helpful for us, especially with respect to the concerns expressed on the other side of the aisle on budget and so on, because that may play into how much this is really going to cost. What kind of training, unique training, do HIV health professionals need to have?
Well, first of all, because of the length of the epidemic, the individuals, the clinicians who were first educated and were taking care of this population are basically now, after 25 years, some of them coming close to retirement. So that population of healthcare providers, some of them will extend obviously longer, but it's really about bringing in training for that next generation of providers moving forward. It is some of the most significant challenges are about managing and helping to support patients, for example, that have comorbidities, multiple diseases at one time. So an individual with diabetes, for example, that is also diagnosed with AIDS, and providing care to those populations with those co-diseases or comorbidities over time in a chronic care fashion. So that's a different set of challenges than we were dealing with at the beginning of this epidemic, requiring a different set of skills.
The other different set of challenges, too, is the increased use and effectiveness of pharmaceuticals.
And so you make a really good point, because many of the pharmaceuticals, for example, are pretty significant in terms of their complexity. You can have difficulties, again, to your point, with drug interactions and toxicities. That's another set, as well as still, frankly, some residual stigma associated with this disease. And so that's another area that clinicians are helped by being trained, by having education about this particular disease that isn't common to diabetes, congestive heart failure, and other chronic illnesses.
Are there changes that we need to make to the Ryan White program to accommodate this training that we're going to have to be providing to the next generation of providers?
And so through the testimony that I provided earlier and mentioning the increased funding amount that we support for the education training centers is a strategy to ensure that providers have that necessary.
So it's really more funding, not necessarily types of training.
But we also have resources that are made available through our SPINs, our projects of national significance, to look at new care models and new care models for specific populations, the type that, for example, Congressman Burgess mentioned, that is people transitioning from incarceration back into community, and what that takes to meet those special health care, the health care needs of that special population.
Okay, just one last area I want to talk about, and that's food and nutrition, because as you know, those are critical components for the survival of people living with HIV and AIDS, and we have a wonderful, wonderful program in Denver, Project Angel Heart, that focuses on nutrition for folks with HIV/AIDS. It can reduce the side effects of antiretroviral medications, make them easier to tolerate. And also, a lot of these medications don't work if you don't take them with food. So I'm wondering if you can discuss HRSA's recent guidance on food and nutrition.
Where is that? Do you have it right handy?
And while you're looking for the guidance, I'm wondering if you have recommendations for food and nutrition services under Parts A and B of the Ryan White program.
So in terms of nutrition services, we have a definition of medical nutrition therapy So medical nutrition therapy that's considered a core service. So we have core services and then a category of services that fall under that definition or fall within that category. We also have a set of services that fall into a category referred to as support services. So now I'm talking about medical nutrition therapy inside the core medical services category. In that, medical nutrition therapy in that circumstance is provided by a licensed registered dietitian outside of a primary care visit. The provision of food, nutritional services, nutritional supplements may be provided pursuant to a physician's recommendation and then with a nutritional plan developed by a licensed registered dietitian. Nutritional services that are not provided by a licensed registered dietitian are considered a support service. Food nutritional services that are, and supplements that are not provided pursuant to a physician's recommendation, again linked to a nutritional plan developed by that dietitian, are considered support services. So you can see where nutritional services track differently as a core medical service and what's required there versus nutritional services that track through the support services category.
Thank you. Thank you very much, Mr. Chairman.
Thank you. And thank you for your testimony. And we may have some additional questions that members will send forth. I know Mr. Burgess mentioned in particular, but we'll get those to you fairly quickly so you can respond. But thank you very much. Appreciate it. And then I'd ask the second panel to come forward.